is called to order. Can I have from our legal counsel our report of the actions taken in closed session, please?
Certainly. The board considered 4 items in closed session. The first 3 were closed session minutes from the September 22nd regular meeting, special meetings from October 13th and October 19th. Those were all approved by the board on a 5-0 vote. And last was a medical staff credentialing, and those recommended credentialing decisions were approved also on a 5-0 vote. That concludes my report.
Are there any deletions or corrections to the posted agenda? Okay. Hearing none, then I'd go to audience input, and this is an opportunity for members of the public to address the board on items that are not on the agenda. So if you wish to speak, if you could raise your hand or use the icon on the bottom of the Zoom screen to be recognized. Once you're recognized, if you give your name for the record, and then you have 3 minutes to present to the board. Just know that if your 3 minutes are up, I might have to have you wrap it up. And we will not be able to make comments on your item because it has not been agendized. So on that, do we have any input from the audience? Hearing none, then I'll move on to point 12, which is input from our Employees Association that are governed by the same rules. Do we have anybody from the Employees Association present? Okay, seeing none and hearing no one, then we'll move on to our item 13, the Medical Staff Executive Committee. And Dr. Lane, you're going to present.
All right. Well, thank you very much. Dorothy, do you want to put a screen up or I can run through this? So we only have 2 consent agenda items. One is from, I don't know what you have first, cardiology or surgery. So the cardiology came up, Dr. Skolnick, our cardiologist, wrote up a our consent form, and this really is the privilege form, and it goes over. First, it was unanimously approved by MEC, but it goes over what kind of experience people need, what kind of core privileges they have, such as echocardiogram, ablation, cardioversion, and it goes over all of the things, and each person signs up for which things that they're appropriate for, and this is pretty much of a general privilege form that we have for every single department. So if there's any questions, I can answer them. I've gone through their privilege form. It all seems totally appropriate. We are doing more of our basic cardiology. We're not still yet at the point of doing heart transplants or things like that.
I did have a question. If I could go first, Director Shamlin, is that it says it's a new privilege form. Had we had one before, or did they come under internal medicine, or why do we have a new one?
My understanding is we did not have one for cardiology before. Dorothy, do you have that answer?
Yes, I do. So cardiology previously was in the internal medicine privilege form. And so at this point, they thought it would be beneficial to just take the cardiology privileges out of the internal medicine form and create its own privilege form. So that's what happened here. So a lot of the privileges on here are privileges that they currently have. We've just pulled it out and made it its own privilege form.
Thank you.
And it makes it much cleaner so that the internal medicine people are not putting down, they can do an echocardiogram or an ablation therapy or cardioversions or pericardiocentesis, other procedures that are very specific to cardiology.
Sure.
Any questions?
Dale, did you have a comment?
No, I did not. No.
Okay.
This is Director Barnett. I just had a question as to what is the size of our cardiology department?
We have 2 full-time cardiologists and then I think 2 APPs. Is that right, Dorothy?
That's correct, yes.
Okay. And then we're trying, so Josh Skolnick is one of them. Tim Lombard, who's a pillar in the community, has been here for a long time. I believe we're trying to find additional cardiologists because at some point Tim is going. I mean, he's going to step down or back off more.
Do we do interventional cardiology?
No, we do not.
Okay.
And that is a high. We don't do. So the patients that we get that require stents or other things, that's an enormous undertaking. It takes a full suite that would be in the OR, a whole team of nurses and 24/7 coverage. And it's you would never see this at a critical access hospital. I will tell you, I mean, and I think the board certainly gets this, but the quality of our doctors is unbelievable given we're a critical access hospital. That when I was the director at Renown, our critical access hospitals in Eastern Nevada were like, they didn't have anywhere near the quality or even the coverage that we have. So doing invasive cardiology, it's a huge step up. It's not a mild step up. We will never be at that. I cannot imagine us ever being there unless we turn into a 100-bed hospital at some point. But so our cardiologists are really skilled, but we can't do those kind of things.
And then, Dr. Lane, what is it? Invasive then? Invasive cardiology?
So invasive. So for instance, a couple of days ago, I had a 63-year-old guy having a giant heart attack. We transferred him to Reno, and invasive is they do the angiogram, they squirt dye in, find where the narrow area is in his coronary vessels, which are the vessels around the outside of the heart that actually give the heart muscle blood. And then they put in a stent, which is a small piece that opens up the blocked area. So the invasive cardiologists have mostly replaced our, when people used to have bypass surgery where you put a blood vessel around all the blocked ones. Now we can usually put stents into those narrowed areas. Or it's people who have abnormal heart rhythms, that there's a part of the heart that we have pacemakers in the heart, and you'll have parts of the heart that are abnormal, and these pacemakers go really fast, give people very fast heart rates, and they can find that spot, go in, and we call it ablation, but it's using usually radio frequency or heat to knock out that small part of the heart.
Because one of the core privileges on the card was invasive cardiology.
And they do very minimal invasive cardiology. We will be doing, we're not doing angiograms, but we will be doing, an angiogram is where you squirt dye into the coronary vessels, look at those. We will probably at some point be doing CAT scan angiograms where you're injecting the dye into a general vein, looking how it goes through the heart. So they are not really doing much in the way of invasive cardiology.
Okay.
Because our system cannot, you need an angiogram suite, and it needs to be 24/7. Like it's an enormous undertaking.
So, Dr. Lane, when somebody shows up at our ER with a heart attack, what can we do to get them transferred? Do you got to give them something to keep them stabilized?
So it all depends on how far out they are. So we do have, so the term is clot buster drugs, which is drugs. So we do have drugs that we give them that can break up the blood clot, that is preventing the blood flow to those blood vessels. Yeah. Or if they come in early enough, we will quickly transport them to a center that's then ready to take them right into the angio lab, find out where the blockage is and open it up. So our facility is very good at giving the clot buster drugs when appropriate, but I mean, it's a big algorithm on what time did symptoms occur, when are we seeing them, how far away is the next person. And so we're able to give very high level care. Obviously, if you have your heart attack, you want to live next door to the hospital that gives angiograms and can do all of that. But we do really well at at everything up to doing invasive cardiology. And so we do a lot of having people in, give them the clot buster drugs, and then they go to the cardiology center and go further.
So, Casey, who did the case studies every year for first responders, ski patrol, and police and fire, I attended one of those just to see what it was like, and he talked about a ski patrolman, an older ski patrolman at Sugar Bowl, who had a heart attack on the hill, and he was in an ambulance going to Renown, but as he passed Tahoe Forest, he arrested, and he was brought into Tahoe Forest where they did something to get him restarted, and then got him down to Renown, and he finished the year ski patrolling at Sugar Bowl.
Dale, what you're saying, that is, I wouldn't say it's common, but it's not uncommon that if someone's stable enough, we'll send them right to the cardiology center or the trauma center. But when they become unstable, obviously, if you lose pulses, we can bring them in. We can do everything that the cardiology center is going to do, up to taking them to the cath lab. And likely they were able to give all the drugs. It's called running a code, where the patient, we have no heartbeat, hopefully bring back a heartbeat with, I mean, the trouble is, in an ambulance, you have one driver and one person in the back. And when they come into the ER, when I'm working on them, I probably have 12 people who are all experts, from respiratory therapists to nurses to everybody, radiology. Everyone can jump in and help. And so we often will take a patient like what you're describing. If we can reestablish a heart rate with lots of people helping, then move them down to the definitive care. Because you can't, doing CPR for 45 minutes and thinking you're going to get the patient back is not very realistic.
Yeah. Okay. Great. Thank you.
All right. Sorry, we're kind of veering off, but any other questions on the cardiology?
Apologies.
Yeah, but we want to make sure that we're doing safe care for these patients too, and that's why we're asking the question.
Absolutely. And our hospital, especially, that's really the emergency department, does a great job on those. They rarely get admitted. If they really need that kind of care, we send them to an invasive cardiology center, which is St. Mary's or Renown. The next one is the general surgery form. This one had a few changes, but it's really, once again, the same thing on what kind of training, board certification, experience, license, malpractice, DEA. And then they list all of the core privileges, and each person who's applying checks off those that are appropriate. So if you're not trained in something, like when we were talking about the previous orthopedic surgeon who did not have knee replacement training, you don't get that skill until you're checked off and you've had sufficient training and multiple surgeries that have been proctored. And that's really what this was. And this was already, it went through the surgery committee. They agreed on it, and MEC did as well. The last one, and this is one that you're going to probably see multiple times, is we're changing what kind of COVID testing we need depending on what the current CDC guidelines are. And it's very basic, but we used to require different pre-op COVID testing than what we do now. And it's really just to make sure that we understand what the patient might have, but really to keep our personnel as safe as possible. So we're getting a little more specific on how much COVID testing we need. Or what kind?
Okay. Any further questions from the board on the privilege forms or the new policy? Okay. Anything from our audience? Okay. Hearing none, can I have a motion to approve the Medical Staff Executive Committee consent agenda?
Alice, I'll move approval of the MEC consent agenda.
Director Barnett seconds.
Okay, so we've got a motion by Director Brown, seconded by Director Barnett, to approve the consent agenda from the MEC, from Medical Staff Executive Committee. A vote, please.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So the consent agenda is approved, Dr. Lane, and you're free to move about the cabin now.
Thank you very much. And then the last thing is Dr. Joy Koch, who's the Vice Chief of Staff, will be, I think she's going to be doing this for our next meeting. I'm going to be out of town the first couple of weeks of November,
Okay.
attending to a really important vacation.
A well-deserved one, too. And we'll welcome Dr. Koch when she's there. All
Thank you.
right. Moving on to 14, the consent calendar. And these are generally non-controversial reports, minutes, pretty much our resolution for being on Zoom. So does any board member have anything that they want to pull from the consent calendar?
This is Director Barnett. I want to pull the 14.2.1, our combined financial statement, just to discuss the change and slight decline in revenues.
Okay, so that we can do that, and we'll have to move it to the item 17, and we'll discuss it at that time. Anything else to be pulled? Okay, can I have a motion to approve the consent calendar except for number 14.2.1 financial report for September 2022?
This is Director Barnett. I so move.
And I'll second it.
Okay, then the
Well, you
consent.
and I have something going on here.
Yeah.
Are you guys talking to each other?
No, I swear.
Okay. So the consent calendar, a motion has been put on the table to approve the consent calendar with the removal of the financial report of 14.2.1. Can I have a vote, please?
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So it has been approved, except for the financial report, which will be discussed in item 17. Item 15 has to do with our Board of Directors bylaw. Last month we had the first reading, and this will be the second reading, and we can vote on the bylaws. The bylaws have to be reviewed at least every 2 years and revised as needed. With this review, the Governance Council looked at it, and there were some editorial changes, just including grammar. There was also revision or adding our current mission and vision statement, replacing the previous one. We added an option for filling a vacancy on the board, and we also put it into the bylaws of the change in the date for the meetings in November and December to be the third, I think it's the third Thursday of the month rather than the traditional fourth because of the holidays. And then the last change was the treasurer no longer has to be the treasurer serves on the financial committee, but does not have to be the chair. And then the chair of the governance, the chair of the board is also the chair of the governance. So those were a summary of the changes that were made in the bylaws. Are there any comments or questions from our board members? Okay, because these are your rules. Okay, hearing none or seeing no hands, is there a comment from our audience? Okay, looks good, huh, Ted?
I had to unmute myself. It looks bueno.
Okay. All right, since there's no additional comments, can I have a vote to approve the Board of Directors bylaws.
Director Chamblin, so moved.
A second, please.
Michael.
Was there a second?
Yeah, Michael, second.
Okay, so it's been moved by Director Shamlin, second by Director McGarry to approve the revised bylaws for the Board of Directors. A vote, please.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGarry,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So the bylaws have been approved. And moving on to item 16, and this is just for board discussion. There's no necessary vote required. And we're going to have a presentation of the fiscal year 2022 annual accomplishment report. And our CEO, is he going to head it off?
Yes. Good evening, Chair and members of the Board of Directors. This is a very special annual meeting of our health system, where we're going to be sharing really a microcosm of a lot of great team efforts throughout the organization. And so this is for our greater Tahoe Forest Health System listening and viewing audience as well. This particular year, moving to the next slide. Martina, can we go to the next slide? Yes, this is our 73rd year since the founding of Tahoe Forest Health System in May of 1949, and it took a few years to actually start treating patients, which we did in 1952, and it's been a tremendous honor and privilege to serve our region with ever-improving public health and general healthcare services over the years. We do have an amazing professional and dedicated team that's really worked tirelessly. They've put it really all on the line for especially the last 31 months as they've been dealing with the COVID-19 pandemic, I think with some of the best outcomes of any health system in the state or the country. And again, this is truly one of the most amazing public health efforts in the last 100 years. So we're going to share with you just a microcosm from several different important segments of our health system, looking at quality, service, people, finance, and growth in the last year. Next slide. The organizational excellence model is really important to us. We have slightly revised our vision, and this is a very tough vision for any rural or urban health system, and that's to strive to be the best health system, to be the health system of choice in our region and the best mountain health system in the nation. And this is something our team is really striving for. Our mission to enhance the health of our communities through excellence and compassion in all we do, and our 5 values of quality, understanding, excellence, stewardship, and teamwork. And I'll turn it over to Louis.
Well, good evening, Chair Wong and members of the board. Before starting, I just wanted to thank Martina Roche for all of her help in helping me put this together. I also want to thank my administrative council colleagues and our directors here at Tahoe Forest Health System for all of their contribution while putting and preparing this document. So I actually get the benefit of talking about the awards and recognitions that the Tahoe Forest Health System has achieved this year. And so if we can move to the next slide, Martina. So Tahoe Forest Health System has successfully passed validation of all 5 domains in the Beta Heart program for the 3rd year in a row. And Tahoe Forest is the only health system to achieve this recognition for 3 years in a row. I think we may have got another health system joining us this year. We congratulate them, but we are the only ones that have done it now 3 years in a row. So Tahoe Forest Hospital has also received the 2022 Women's Choice Award for Best Hospital in Emergency Care, Obstetrics, and Patient Experience. We were also named the 2021 Guardian of Excellence Award winner by Press Ganey for the 3rd year in a row as well. And Tahoe Forest received the 2021 Truckee Resilience Award by the Truckee Chamber of Commerce for the critical role played by all of our staff throughout the COVID-19 pandemic. Dr. Laney Andrews, emergency physician at our Incline Village Community Hospital, was named 2021 Northern Nevada Physician Healthcare Hero by Nevada Business Magazine. And Tahoe Forest was also recognized for excellent progress in 2021's California Opioid Care Honor Roll program. Again, Tahoe Forest earned the California Maternal Quality Care Collaborative Maternal Data Center, or easier way to say that, MDC Superstar Award for small birth volume hospitals. This award is awarded to hospitals with fewer than 1,000 annual births that exhibited high levels of engagement in the MDC program. And Tahoe Forest was also proud to be awarded for the third place in the extra large business category across all industries in Northern Nevada Human Resource Association. This, of course, is an award we've won a number of times and something that we're very proud of here at Tahoe Forest. And for the 8th year in a row, Tahoe Forest was recognized as Star Performer for its achievements and participation in Own the Bone program. It's a quality improvement program highlighted by U.S. News and World Report. And we also are Star Performers, demonstrating a commitment to helping patients understand the risk for future fractures and steps they can take to prevent them from achieving a 75% compliance rate with at least 5 of 10 Own the Bone prevention measures. I also want to recognize Jake Dorst, our Chief Information and Innovation Officer. He was named once again on the Becker's Hospital Review list for CIOs to know, and that's a national award. Continued as a designated UC Davis Rural Center of Excellence by maintaining excellence in clinical care, education and training, and clinical research. And Tahoe Forest maintained its National Baby Friendly designation. And with that, I'd like to pass it on to Jan to talk about quality here at Tahoe Forest.
Hi, good evening. So the first slide here talks about the quality and some of the metrics we've looked at and some of the, obviously some of the nursing areas of both hospitals. This combines Tahoe Forest and Incline where it's applicable. So for class 1 infections, as you can see over the years, we have done very well. We were for fiscal year 2022, we were at a 0.68%, which is excellent. For our emergency department transfer communication, as you can see, we kind of started on the low end and we have definitely made big improvements in that, and we're at 99.45%. For sepsis. Sepsis has been a huge campaign for this hospital, and we have, back and forth struggled on this. And this year we did have a little bit of a fallout, so we dropped to 87, almost 88%. And some of it is simple measures of not hanging an antibiotic. And if we have a small number of sepsis patients and when we have one fallout, it can make our percentage a little lower. But this is still a huge strive in our system for all the nursing units. It's not just the emergency room, it's ICU, med-surg, OB. So we are all consistently watching sepsis, and we do have in our EPIC system what we call flags to let us know when the system flags it that they think this is a septic patient. For the medium time to EKG, we do very well. We're at 7.5 minutes. That means from the time you walk in the door to the time we get an EKG done on you. If you're complaining of anything to do with chest pain, we do that in 7.5 minutes. And then our hospital acquired C. diff, we're at 0.338. Right now we're at like 416 days with no C. diff infections, which is really a huge accomplishment. And most of this comes from our inpatient unit, meaning our ICU and our med-surg unit. Next slide. So obviously the COVID pandemic still was with us in our fiscal year last year. So the health system started several pediatric clinics for COVID-19, which was huge for our community. And thanks to the staff who did that, lots of staff did that on Sundays. That was the best date they thought that would work for our community. And then, as you can see, for our statistics for fiscal year 2022, we did 22,215 COVID-19 tests and 724 vaccines were administered. And that was the ones we did here in our system. Patient safety, as Louis mentioned, we just participated in our 5th year of the Beta Heart. I was very lucky to be at that conference last week when we received the Beta Heart Award again. Believe it or not, it was our system against USC. And with USC, there's 5 hospital systems. So it's a pretty huge honor for us to be against such a huge medical system for our Beta Heart culture. We also participated in the SCORE survey, and to have an 84% response is really great. Most hospitals are very happy if they get 50% response. So for us to get 84% is really great for our system. And obviously it lets us know where people feel we're lacking in our safety. Both Tahoe Forest and Incline received Tier 2 Quest for Zero Excellence in ED. This is for both emergency rooms, and this is a collaboration that they're focusing on. Also, they're focusing on the pediatric readiness for both emergency rooms. So we have upped our training in pediatrics. We've upped the equipment that we have to take care of these pediatric patients. And we were honored for that by receiving the Tier 2 award. Also, the OB staff received a Tier 2 in excellence in OB, and they focused this year on fetal patterns and uterine contractions. And as we all know, OB does a great job on their simulation drills and their postpartum hemorrhages. Next slide. For CMS, for Centers for Medicare and Medicaid Services, we were focusing mainly on our readmission reduction strategies, which we've included the correct discharge codes so that if we get an expected admission reback, is it really a readmission or did we code it correctly or code it wrong the first time? We also focused on TCM, which is our transition of care management, focused on high-risk STAR categories and the Tahoe Forest opportunities that we're going to participate with the Health Service Advisory Group and doing chart audits. We increased follow-up visits for all discharged patients. So we're trying to make the appointments for the patients prior to discharge so that we can make sure those patients are able to get those appointments in our system, especially with some of the access to care. And home health has been practicing changing their change not to discharge a patient before the 6 visits because that affected our rating too. And then we've done really well in our development of the behavioral health and substance use disorder service lines. So we've started those programs through the emergency room, and we have really seen a huge change with that, especially with our medication assistant therapy program. Next slide.
Okay.
Louis, on to Louis.
Now, moving on to diagnostic imaging. So diagnostic imaging upgraded to a cloud-based imaging share called Purview. And so now patients can receive requested images via email and immediately share those images with providers. So no more having to come and pick up CDs. So we can get that information into the right hands at the right time in a much quicker fashion. DI began participating in the national quality measures of breast centers to ensure Tahoe Forest Health System compares to the highest quality standard in industry, as well as paralleled or better turnarounds for exams and subsequent imaging needs for mammography. Briner Imaging Center made advancements to its 3D mammography exams with the addition of Genius AI. It's a detection technology, and it's the latest breakthrough in breast cancer detection. As far as I know, I think we are one of the only hospitals in the region to actually have this technology. And Briner imaging was published in the Barrel Institute to a showcase a process improvement that significantly reduced the turnaround time for mammograms, ultrasounds, and biopsies. And so I also wanted to bring up quality in laboratory. As we know, laboratory has been working very, very hard in terms of COVID response. And so this year, lab was able to also implement some change, even with that increased workload. Tahoe Forest Lab added a blood culture pathogen identification panel to the BioFire instrument, and also added a syndromic trends software to BioFire, providing data on local and regional pathogen circulation to support antimicrobial stewardship and infection control. And we'll move on to Scott, our VP of Physician Services.
Good evening, Chairman and members of the board. As all of you know, a hallmark of our medical staff is the concentration on evidence-based medicine, and in the surgery arena, we now know through evidence-based medicine that surgical outcomes are often predicted through certain markers and how well the patient is prepared for surgery. So an initiative that we put in place this year is a preoperative clinic, which funnels all of our surgical cases through a process-driven screening, and using the skills of Dr. Nicole Jernick, review all surgical cases that meet certain criteria in order to ensure that they're properly prepared for the best possible outcome through their surgical experience. That often includes not only nutrition, as you see on the slide, but also controlling diabetes, high blood pressure, a list of other markers to ensure the best possible outcome. Next slide. We could talk all night and brag on our cancer center for a long period of time. All of their measures and comparables are always well above any national or state benchmarks. You see on the screen some of those measures, always 98, 100% of the quality initiatives that come with some of the accreditations that they have met over the years. As well as some of the grants to get patients through the door and reimburse them for travel to ensure that they get the care that they need and the highest training possible for their staff. Next slide. Same thing. The quality measures reported through COPE is in the 1% of the cancer programs across the country. The clinical trials program, through the leadership of Dr. Tom Simrad, continues to expand and provide our patients to access to clinical trials that most programs just simply don't have access to. In addition to being one of the rare quadruple accredited cancer center programs in the country, this year they also earned the APEX accreditation through the American Society of Radiation Oncology. And I think I send it back to Jan.
Yes, thank you. So this year, as you're aware, our emergency room received its level 3 trauma designation by the Sierra Sacramento Valley EMS agency, which is what Tahoe Forest is part of. And we are going to wait for that final verification in May. We've already got our date in May of 2023 for the American College of Surgeons to come back and survey here at Tahoe Forest. The emergency department hired a substance use navigator to improve the services on patients arriving in the emergency room with behavioral health, but also with the substance use. And this is where that medication-assisted treatment has really made a difference. And as you can see in the graph below, how many patients get referred and how many patients are treated, and if it's alcohol or if it's opiates, and then what medication-assisted treatment is seen. And then they also get the follow-up care. So as you can see in our area, alcohol is still prevalent, and our drug use is a little lower, thank God, but we are able to get these people hopefully into the appropriate programs so that they can begin treatment. Next slide. The intensive care unit here is increased from 3 RNs that were CCRN certified to now 9, which is pretty remarkable for a small ICU. Our sepsis monitoring went from 65% to 83%. So like I said, we're really focusing on sepsis. I don't see that ever going away in our system. And then we've been looking on our door to discharge times, and we decreased that from 153 minutes to 144. We're still looking for bigger improvements in that realm. Next slide. And then for our community, this goes back to Louis. This is
it does, yes. Thank you. So yeah, we wanted to speak a little bit about our community health and QIP. So we have successfully completed and reported on a triannual community health needs assessment. We've expanded outreach and support for patients with complex medical needs and social needs by hiring 2 additional community health advocates. You may hear them as promotores. We also are involved in a zero suicide initiative. We've met the staff training need identified in the 2019 employee survey. So we've surveyed in 2019 and we've been able to meet the needs of the staff that came to the top of that survey. We now, in fact, are going to go back and implement another survey for the 22 year, and we'll continue our efforts in the zero suicide initiative. We've implemented Talk Saves Lives training for all staff, and we've also implemented the Columbia Suicide Severity Rating Scale and trained nurses in the ED and inpatient units. And in terms of QIP, we've expanded the number of reportable metrics through the Quality Incentive Pool program for Medi-Cal patients to include additional preventative care metrics. And I will pass it back to Jan to speak to you about service.
Thank you, Louis. So for patient satisfaction, as you know, we strive to really give the best patient care experience here at Tahoe Forest. And so what we really look at is that percentile ranking for Rate Your Hospital as a 9 or 10. We remain at the 99% rank. And then for recommending this hospital, we also remain at the 99% rate. We attained the 4-star for the HCAP 2022 star rating, and this is a 1 to 5-star scale based on 11 publicly reported measures in assessing the patient care experience. And then our overall patient satisfaction score for our fiscal year 22 was 94.42. It exceeded our goal of the 93.76. And as you can see, our past scores are listed below. And, we kind of hover in that little area. There's always area for improvement. But, we're holding strong and we continue to do really well. Next slide. So our perfect care experience training was reinstated. Obviously, after, COVID, we were not able to do classes. So we're trying to get these classes back in person again. And so we're trying to educate as many of our employees as possible. There was a internal customer service video using the improvement grant that we received, the small rural hospital improvement grant SHIP award. And we showed that video to staff. And I'm sure some of you also saw that when we were at our events in August, September. That video was shown. Our outpatient improvement team continues to focus on the experience of outpatient services. We have volunteer ambassadors that were trained to help patients navigate the health system. We're always looking for ways to help patients who are having difficulty making appointments or following up with certain appointments or getting medication. So we're always looking for ways to help our patients through the system. We also do the service recovery toolkits, which I've got to give Janet's team a big shout out in quality. They really look to see what we might do to help patients that have complaints and how we can minimize those complaints, but also when we do have to do some service recovery. We also are celebrating our 8th year with our Patient and Family Advisory Council volunteers. We've had 11 volunteers who have been actively engaged in the operational, and they make great suggestions for us to improve our health system and our processes. So we always welcome their comments and what they have to tell us at their meetings. Next slide. I think that's it. Pass it on back to Louis.
Actually, I think it's Alex this
Or
time.
Alex, goes to Alex, sorry.
That's okay. So good evening, everyone. As you know, we cannot do any of the things we've talked about today without our outstanding people. We grew to 1,239 employees, which includes 62 employed physicians. Our medical staff grew to 175, up 115 since fiscal year 2015. We also welcomed new volunteers, and as you know, we finalized our memorandum of understanding with our Employees Association and Employees Association of Professionals, which is a lot of dedicated work from both the district side and the employee side. So just kudos to everyone there. We had a lot of things going on benefits. We did change the benefits to go to a virtual format as well as in person when we can. Those are actually going to be kicking off next week. We launched Talkspace, as you know, and this was an opportunity to provide mental health support for our employees. And we found that 218 people have participated in that. And I just received a report the other day that I think it was 60% of those have seen improvements. So really great benefit that we added there. Rocket Lawyer was also added. This is the benefit that allows access to legal documents, legal advice, all free of charge for our employees to a certain extent. Next slide. Okay, as you know, we do a lot of engagement activities through the years, or through the year, and we did the one I'll point out specifically here is we changed our recognition program from our employee of the month program, which really only recognizes 12 people throughout the year. This allows us to recognize many more people and also celebrate even the nominations. So we get together quarterly and we have an award ceremony. It's a really great event. Some of the other things we did this year is we gifted emergency go bags with emergency shelters. You know, we want our employees to be prepared. We do live in a wildfire area, so we want people to be prepared. We had food truck events. We went to the Reno Aces, and of course we had pumpkin carving and gingerbread house contests as well. Next slide. Okay, education. We did a lot of education this year. Couple specific ones, 13 RNs in the ED achieved their mobile intensive care nurse. I think Jan talked about that a little bit. 15 simulation events were conducted. This really helps our med-surg, ICU, Women and Family Cancer Center, urgent care clinics, just staying competent in their roles. We initiated the RQI program for neonatal resuscitation. The RQI program actually assists with what Dr. Lane was talking about earlier with our code response. So it's really, it's the best way to teach CPR, if you will. And in this case, it's neonatal resuscitation. And so we're kind of some of the first organizations to adopt that. We're really proud of doing so. We held our annual Winter Illness Injury Symposium this year, or excuse me, last fiscal year, with over 300 participants, which was virtual. That's the event that Dale talked about attending live one of those years, a few years back. We are going to be having that event this year in person over at the Hyatt. I think it's the first Monday in December.
I'm signed up.
Oh, excellent. Excellent.
And so is Bob Barnett.
Yeah. It's a great event. And we designed this event specifically for our pre-hospital folks. So specifically our EMS folks, our police, our search and rescue, but of course hospital is very welcome to attend, and it's very relevant for them as well. But it's kind of a thank you for those pre-hospital folks. And we also added a virtual video library just for folks to stay, again, competent in their role, get on the job training just by scanning a QR code. It brings them to a video. They can get a quick 5-minute video on how to do something. And I think we're going to head over to finance and Crystal Betts, our Chief Financial Officer.
Alex, could I ask a quick question, clarification on, you said 62 employed physicians. So I assume that does not include ER and anesthesiologists who are not yet employed?
That's correct, yes. And again, keep in mind, these numbers were from the end of fiscal year. So that was back on June 30. Okay,
but I also hear from time to time that we have roughly 140 healthcare professionals, which would then include ER plus anesthesiology plus
I think NPs those are
NPs and PAs, right?
Yeah, that would be our medical staff providers. Yes,
Okay.
the whole. So these 62 are included in that 150 or whatever that number is.
Okay.
Dale, most are employed except for emergency department and pathology, with very minor other exceptions.
Right. Okay.
Thanks.
Okay, are we ready to move on to finance?
Absolutely.
So, as you heard at our last board meeting, when I provided some education on the No Surprises Act and the complexity of that, that was a huge accomplishment for several of the departments that roll under finance of the implementation of those items within the No Surprises Act. It took a village to put that in place. So we are very proud of that. We still know there's more to come, but it was pretty substantial for several of the departments within finance. Access Center, a couple things to note. They worked really hard on trying to figure out how they could change things around to help reduce the no-show and the late cancellations, to improve our patients showing up in our clinics. So they really worked hard to try to change the frequency of those reminders to just remind people that, hey, you got an appointment, let's get you in. We also worked very hard on trying to create what we're calling a hometown feel, that if there was something that we could not help the patient with through the Access Center and scheduling, that we would try to always do a warm transfer to the location we needed to get them to. So instead of just cold transfer and who knows if someone picked up on the other line to help them, we waited for someone to answer and then handed them off to an individual to make sure the next step in their process was handled by someone internally. So we worked very, very hard to try to keep that going. We've included a few stats for you. It's amazing how many calls they actually handle and authorizations, as well as working referrals. We had a 22% increase in the number of referrals that we handled for patients when compared to 2021. So quite a bit. Next slide. In the area of patient registration, a couple things that we did. We used to contract with a company that would provide us an individual that when we came across a patient that we thought might qualify for Medi-Cal or Medicaid, that they would assist that patient in getting that coverage. Well, we had found that the reliability of the company in providing us a dedicated person was not up to our standard. And so we decided to bring that in-house and train our own person to make sure that we were there to help our emergency room patients or inpatients or anyone that might be self-pay, trying to get them qualified for Medi-Cal or Medicaid if they were eligible. In addition, we trained our own people for greater coverage for the hospital presumptive eligibility program. And basically what this is if we feel someone meets the criteria for Medi-Cal, we can get them temporary coverage, and we will get paid for the service we provide to them while they have this temporary coverage. So by providing this on weekends and after hours, it really helped improve having some coverage for our patients and helped the hospital get reimbursed something for the care that we were providing. Within HIM, our Health Information Management, a couple things we did there. The biggest one being that we onboarded a new coding company, which has been just a big win for us. The quality of the staff, the working relationship, the turnaround times, keeping our discharge not final billed consistently low has been outstanding. So that was a great accomplishment that we were able to do. And then we provided a few other stats, really working with the providers to keep their delinquent chart rates down, making sure we're getting our patients or the providers that our patients are going to go see, that we get those medical record requests turned around quickly. And then, of course, we're always auditing and checking to make sure that things are staying on track and that we're in compliance. So, and of course, several of these departments are super excited that we now have the Corporate Point Reno location and that several staff are now down there, and that has made them extremely happy and has been a wonderful recruitment tool. So next slide. In the accounting department, we've been working very hard on the implementation of what we call Axiom and their suite of products. We completed the implementation of productivity management, which will provide our departments daily and biweekly productivity reporting so they know how efficient they're operating. We finished the implementation, and then we're going to start rolling this out to our departments next month. So the implementation is complete, and we're getting ready to go. We were also able to move into our final stage of the cost accounting and decision support module. This is one of those programs where you can ask what if. What if we decided to do less hips and knees and more shoulders? Or, does, Dr. So-and-so, is he more efficient and cost effective than Dr. So-and-so? So it's just a tool that allows us to do a greater in-depth analysis, which we've been dying to have. So this is going to be a wonderful thing. And then we work with US Bank to do Cash Arc, which will really help the efficiencies in our cash posting to reduce our AR days, which we all know is always our mission. In materials management, a couple points there. Matt Rouse, our director, has revitalized the product evaluation and standardization committee. This committee evaluates products that we use and either, recommends moving to something different because it's higher quality, maybe lower cost, similar cost, but it brings everyone together to make that evaluation take place. And it kind of fell off the radar for a little while, especially during COVID. So we were really happy that we were able to revitalize it again. And of course, they did a wonderful job with our inventory and managing our capital expenditures in fiscal year 22. So next slide. Revenue cycle. Even though we have a revenue cycle department, these items really touch every department within what we call, the finance department. So patient registration, the business office, et cetera. We had a big project with Mercy, which was called the Plan Master Insurance Code Project. It allowed us to retool how the insurance plans were located within the Epic system, making it much easier for a registration clerk to pick the proper plan. So we didn't have problems downstream when the bill was actually, or the claim was actually sent. So that was a huge undertaking that has helped us tremendously. And of course, with our growth, we've had to do additional clinic builds within the Mercy system so we could bill for these locations. And you can see we had quite a few. We had the Incline Rural Health Clinic. The second floor of the Cancer Center is now a rural health clinic, behavioral health, radiology, anesthesia. We've worked on all of these to get them ready to go. So that was a massive undertaking, and it took a village. The stats here, just real quick, you can see fiscal year 22, we had our highest average daily census since 2012 on this slide and our longest length of stay. So we were very busy on the inpatient unit for sure. Next slide. Deliveries. So we had 366 in 2022, was definitely busier than 2020 and 2021. We tend to hover, as you can see, right about that 350 mark. So just a slight uptick in 2020. Emergency department visits. We definitely crept in 2022 again. 2020 and 2021 when COVID hit, we definitely slowed down. But we took the uptick in 2022 and got back to normal levels. Provider office visits, we didn't quite see as much growth as we had hoped for, but we still definitely had some growth. We missed our target, as you'll see when we kind of review our metrics, that we missed is just ever so slightly, but we did see an increase. From a financial point of view, it looks a little weird for 2022. And by the way, when we put these slides together, we did not have the pre-audit or audited numbers. So they did change with the GASB 87 lease regulation and with a couple of other adjustments we made. So please keep that in mind. But you can see that the cash current versus cash reserve changed quite a bit. And that's that investment portfolio that we now have with Chandler, shifting into, that cash reserve fund instead of that operational account. Cash collections just shows that we've increased our cash collections and our cash per day, which is the slope of what we want to see as we move forward. Next slide. Our assets on our balance sheet, same thing. We want to see that upward movement of that line, the trend going upwards, which we definitely saw in 2022, as you just saw with the audit report. Next slide. Same with our net position, or for some of you, that might be like retained earnings, if that's a name you recognize better. When we have net income, it raises our net position. And so you can see in 2022 that grew as well, especially since you just saw the audit. Next slide. And so really on this slide, what we're looking for is that top line is our net patient revenue. And we want to see that white gap between the net patient revenue and the expenses below that. That shows that we're actually achieving some net income that we can then use to reinvest into the health system. So that is a positive trend that we're seeing with that gap between net patient revenue and our expenses. And this is the margin. So basically that white gap materializes into these numbers, and you can see the trend that we want to see. And then this slide, I'm going to ask for Jake to probably take a little bit of the bottom items. We kind of tag team this a little bit here. But from a technology point of view for our revenue cycle, we did onboard Ability as our clearinghouse, which really helped us streamline our revenue cycle. We talked about the No Surprises Act. We talked about the systems we had to build for radiology and anesthesia. Really worked on trying to streamline our workflows for our room and bed charges. We completed the build for the second floor of the Cancer Center Rural Health Clinic. We have our new coding company, Imagine, that we brought on board. And one thing we didn't note on the other slides was that we did convert to a new billing company for the skilled nursing facility. That's a very specialized billing. And this billing company, it's just what they do, and they've done an excellent job for us. So moving on into the Epic EMR system, I'm going to kind of turn this over to Jake because I did not participate with a lot of these items in this section.
Good evening, board. This is Jake Dorst. I am the Chief Information and Innovation Officer serving at Tahoe Forest. So with any organization, any healthcare organization, there's always optimization of electronic health records, Epic being no exception, probably actually more so, because they're constantly changing and growing and meeting new federal and state guidelines. So we have to pivot with them. Luckily, they're a good partner between Epic and Mercy. Really do look after us and help us make sure that we're current and all those things. So you can see here, just briefly, we've done some dosimetry portal through our ARIA software in oncology, restructured rehab therapy, Olympic Valley and sports medicine departments to ease the billing. We built a EMR archive when we took over the North Tahoe orthopedic patient records, so we were able to go back and look at those legacy records that were in a system called Emma. We created some new work queues to speed up some orthopedic prior authorization. So a lot of that work with the finance portion and technology was done with the orthopods. So I guess this is me. So I'll continue to go. Thank you, Crystal. I'm not going to read through all this. I think I've got 5 or 6 slides. They were truncated for brevity. But again, my name's Jake Dorst. I'm the CIO. A lot of the things I do here are aligning up a lot of the IT objectives with the programs and strategic priorities of our entire C-suite. That includes providing leadership to the IT department. I am also over the project management office, headed up by a great team, by Jeff Rosenfeld and his crew, who have been super busy. We'll get into some of that. But you can see here, implemented a lot of adolescent screening tools, credentialed additional trainers in Epic, clinical application folks. We had 2 upgrades in Epic in August 2021 and April 2022. We put in new Nihon code and bedside monitors and integrated those. We've got all kinds of new instruments, which is, you may hear the term IoT out there in the wild, which is the Internet of Things. So they're not necessarily computers, but things like Baxter infusion pumps. We helped negotiate and purchase those and implemented and rolled them out. When I had my appendix, they click a lot. They're kind of loud. It's like, man, this kind of, and it's syncopated, so it's not very rhythmic. So it doesn't help you sleep like a clock. We did a full interoperability analysis in Occ Health and with diagnostic imaging with a company called Hologic for that secure exchange between those. Integrated the BioFire that we put in for COVID. Guess that's it. The next slide. So Fortified, we talked with Fortified. They came out. They're our partner that does our annual HIPAA security audit and also meets with us monthly to go over new and existing threats and assessing our resilience to those in the wild, which has helped us a lot. I think that's a big part of the job of a CIO, is really first and foremost is patient safety. The next is making sure that we're able to bill and collect. And then on top of all of that is security. And you all know, you read the news, there's hospitals getting had, as we say, all over the place with malware, ransomware, etc. So staying on top of that is a full-time job. We went with Fortified Security, as you know, because they specialize in healthcare and hospital operations. So they understand the business better. I know I've worked with other companies and prior employers that weren't really healthcare based, and they're like, "Oh, well, we have to take the system down." And I don't know, it's 2 PM. You can't just do that in a hospital. And they're like, "Okay, well, this is important." So, but they understand and they work with us for those odd hours that IT and healthcare has to work. So looking through, we also identify the business drivers with the strategic objectives and priorities of the organization, reducing cost, negotiating with our partners. We've done a lot of that this year. It was a good time to negotiate. People were looking to reduce their costs with COVID because there wasn't a lot of buying going on. I guess we can move on. Again, I know you guys are seeing this for the first time, and it's a lot. If you read this later when you can't sleep, let me know if you have questions. I'm a email or phone call away. So material risk, we're continuing to really look at what are the regulatory requirements and meeting those criteria. NIST is a big government entity, National Institute of Standards. They have put out a lot of best practice guidelines. It's hard to meet those guidelines, unless you have a government budget. But I think we are light years from where we were when I started here, as far as security and really understanding our security posture and how it reflects the internet to the outside world. Incident response planning and capabilities. So that's basically if we had how would we respond to that? And what systems are absolutely critical to continue working? And how fast can we get those up? You don't want to get into what's called a bare metal recovery, where it's just you start from scratch on the server, and then you have to contact all the vendors and say, hey, we need you to rebuild a lot of this. We don't ever want to be in that situation. So we do backups and snapshots of what we have in our virtual servers, which are, instead of physical boxes, they're kind of servers that live inside the memory of a computer. So you can take quick snapshots and you can restore quickly as well. We did some penetration testing from third parties. So we have basically what you call white hat hackers come and try to breach. They don't tell us when or how they're going to do it. Gaps were discovered and we immediately addressed those. They couldn't get past our firewalls though. So they got into the network, but they tried to execute any kind of malicious code. And with our Palo Alto and Aruba backgrounds, they were not able to affect those changes. So that's good. And I think I skipped over, but we're going to do a tabletop exercise next month. We're in October. To really work and look and say, okay, if this happened, how would we do it? It's basically a drill. And we're on top of everything else trying to get that squared away. So the external environment, technology, the security threat, everything really comes through email. That's the main avenue for malicious actors or bad actors to get into your network or get past your security. We have some pretty advanced software that looks for signatures on our firewalls that will monitor those types of things coming in. If someone gets something like that and then executes it, clicks on it or starts the program, whatever, it's able to stop it before it spreads. That's with the Palo Alto. It uses artificial intelligence and machine learning, as well as known actors and signatures for those, so they can let us know quickly. And we've been really good at proactively shutting those things down if there's ever any past the first gate kind of situation. So we're focused on a threat defense approach, and we want to stop anything before it gets here clearly. And I think we have pretty decent tools to get in there and stop that. So we can continue on down the security strategy, reducing those threat opportunities. We've been cleaning up what's known as the Active Directory, which is our user kind of database, if you will, that Microsoft sells. That's what we use. And that gives rights to certain types of employees to access certain areas of our PHI. Multi-factor authentication we have with, when you try to log into our network, you have to have a application that's set up on your personal phone to approve that login. And that has helped tremendously. That's kind of table stakes at this point. Everybody should have that. You see it on your Gmail and your Yahoo and all that now, and Apple. We have looked at, got some software. It was relatively cheap, actually. I was happy about that. But that's helping us ensure that all of our patches and updates are applied. Having to rely on human memory to do that is not always the best way. 0 day is, I guess, tech speak for previously unknown viruses. So a 0 day virus is usually installed and waits, and it all kicks off at once. You probably remember the worm virus that was all in the news several years ago, but it all affects everything all at once on a certain date and time. It all kicks off around the world. Once that happens, those signatures get put out pretty quickly, and we have good partners that are able to security operations partners that are able to give us those signatures quickly and shut down our vulnerabilities. You can go to the next one. So the new normal for TFHS cybersecurity architecture, we're really looking at how do we modernize that. And a lot of those steps were taken by moving to Palo Alto and moving to Aruba, which we put in, 6-7 years ago now. It's done us well. It's provided a really good platform for us to stay safe and secure, knock on wood. And, our spam filtering and our malicious email filtering has also improved. And we're really driving that to make our end users happy and satisfied with and keeping us safe without putting a huge burden on them and limiting their ability to do their job with the tools that they have. Next. That's it. So I think Matt will take it from here, Mr. Mouche.
Jake, just a quick question from Dale here.
Yes, sir.
These bad actors that try to invade our system, do they always do it for purposes of ransomware, or do they sometimes just want to disrupt for whatever malicious reasons?
Well, money makes the world go round. You know that deal. So
yeah.
Most of it is for personal enrichment. There have been some stories out there that, people have paid the ransom and gotten the keys, and they still deleted everything. So the best defense obviously is a good offense. And really making sure we don't get into that situation. I do have a couple Bitcoin in case we need it though.
Yeah. Okay.
I know how to get more.
Yeah, good.
And the other thing too, Dale, we do is we know what countries that these come from, mostly from Russia and China. So we geofence from there. So every computer has an IP address, which is like a telephone number, and it's unique to them. So we have in our firewall, our Palo Alto, that basically says we're going to geofence all the IPs that come from this country, so we can severely limit the ability for them to even make the phone call, and so to speak, to even make the connection. So that also helps us a lot.
North Korea on that list too?
Oh yeah, man, that's a long list.
Okay. Thank you.
All right. Thanks, Jake.
My pleasure.
I'm actually in awe from all of that. I did not know we hired white hat hackers
every year.
Good to know. I will speak briefly and generally about our legal services. Mainly what we accomplished this year is becoming more proactive. What I mean by that is we had almost as many cases as a plaintiff, which is strange for a hospital, as a defendant. This could be things like withholding money from companies that had penalties from their contracts, or recouping dollars from vendors that didn't actually earn it. Most of the time, hospitals don't have the time and the effort to do this, to go after their lost dollars. So that's a good thing for us. Mainly how we do that, though, is forming good working relationships, business relationships with each department, and advising them before it gets to the point of any errors happening. So those inward relationships and the teaching are what really helps. We have not, I'll tell you, the results of that is we have not had a negative judgment against the district during this past year, or for that matter, the 6 years before that, in any area. And those include some door closing events, as they're known, which could be Stark Law, IRS, false claims cases, which we've had. It also includes all the labor suits that we might get from employees, medical malpractice actions from patients, and transactional disputes in any one of the 1,000 contracts that we have. So it's a pretty monumental feat. I'm pretty happy with that result. But again, the real work comes from the education and the planning within each department and all the amazing people that we have working here. So that's pretty much it. This is a really different vision for legal services to be operating in this proactive approach instead of the reactive approach where you just wait until a problem hits your desks and then respond to it. So I'm happy to be a part of this team that and able to operate this way. And with that, I'll pass it on to Mr. Scott Baker.
Thanks, Matt. As Crystal indicated earlier, we saw some growth, although it's not the tremendous growth that we've seen over the last 3-4 years. We still saw some growth in the outpatient clinic setting. The list that you see on your screen are where we saw revenue growth for the year, either at the prorated price increase that we do every year or greater. This list is much longer than the next slide because a shout out to our revenue capture team. The level of acuity that we see in some cases has gone up. So while we didn't see the tremendous growth in encounter volumes, we still saw a pretty generous increase in revenue in the outpatient clinic setting in these departments. The next slide shows some of the heavy hitters on increase in patient encounters. While we show a modest increase of a little over 3% across the board, these departments saw a pretty tremendous growth through the year. So still a pretty good list of departments that saw good growth for the year in patient encounters, either due to additional providers coming on board or efficiency in the clinics and seeing more patients per providers. More often than not, it's a combination of those two. Next slide. Even more important than the number of patients we see or how we see those patients, you see in front of you a list of process improvement projects that we incorporated this year. iovera is the non-opioid nerve block agent in orthopedics. You heard about the robotic implementation for knee surgeries earlier in the year. And the list continues. A lot of the programs that you see are hundreds of hours of implementation, all with the goal of improving the care that we provide to our patients and the support mechanisms that we provide to our physicians and clinicians. I'll call out on the last slide the increase in behavioral health department. We are planning to continue to incorporate behavioral health in every one of our RHCs, every one of our primary care departments. And that department saw tremendous growth in the number of providers and the number of encounters, with more to come this year. This next slide will show part of our strategic objectives for this year and last year are improving the community partnerships we have. The list you see in front of you are agreements that we either started or improved upon this past year in the vein of athletic trainers on site for some ski programs, physicians and APPs on site for athletic events and things of that nature. So really strong ties to the community, which is an important part of our strategic plan. And the next slide, I believe I pass it over to Mr. Ted Owens.
Thank you, Scott. Chair Wong, Directors, Ted Owens, Executive Director of Governance and Business Development. As you know, we adopted a 3-year strategic plan in February of this year. That was a broad team, multidisciplinary, and notably, I'd like to point out we had physician input, a great deal of input and volunteering of their time. I'd like to pass a thank you on to our former COOs, not with the organization any longer. She's retired. Judy Newland did a great job of coordination in leading this particular effort. In the neighborhood of a partnership building, we supported a number of grants for a number of organizations. Notably here, we have the Town of Truckee's FTA grant, which supports the Dial-A-Ride or paratransit program for members of the community that require ADA assistance for transportation, not to be confused with TART or microtransit, which I'll get into right now. We were a funding partner in recognition of the microtransit program that Placer County initiated a year or two ago in eastern Placer County. The town of Truckee initiated a summer microtransit pilot program. We were a funding member, an active member of it. It was very, very successful and very popular with our staff in their efforts to provide transportation to patients both to and from our campus. You may not realize it, but Lyft and Uber and taxi services are greatly diminished as a result of the pandemic. So this was a very popular program. Added note, the town council decided last week that they would do another winter pilot program that will begin on the 15th of December and run through early April. And again, we are a participant in that particular program. In addition to that, we do serve as a member of the town of Truckee's Microtransit Feasibility Committee. It is the goal of the town to try and establish a permanent microtransit program here. We're very proud and honored to be a part of that effort. In addition to that, we do other things like advocated and supported for the 5-year contract, extending the CareFlight contract with the airport. They're required by the FAA to put that out to an RFP every 5 years. And we played an active role in ensuring that CareFlight would remain the provider and be located at the Truckee Tahoe Airport. Next slide. We're very unique in that our members of our leadership team do provide their time and efforts on a variety of boards in statewide associations as well as local. They're listed here. And certainly with the addition of our new COO, Louis Ward, we're expanding that net even further. We participate in state associations related to healthcare. Locally, we support other issues and serve on things like chambers of commerce. Of course, the Workforce Housing Agency that we were a key player in the development of, and we will continue to do so as we move forward. We are closely and very active on the political front with a variety of state associations. We work with the ACHD, DHLF, and certainly the California Hospital Association in those efforts. If we could move to the last slide. 36 letters were written either in support or opposition to pending legislation. We are very active in that, but we are also called upon very often by lobbyists to provide information just as our own organization, which is a really nice honor to have. They respect us quite a bit, and they like to run pending legislative concepts and ideas by us, and we do participate in that. Earlier this year, we were able to attend for in-person meetings with legislators for the first time since the pandemic. I'm glad that we did because it plays into the next bullet point. We did play a strong role because we were in person, I believe, in defeating AB 2080, which was that Consolidation and Contracting so-called Fairness Act. It was very similar to a bill that was carried by Mr. Weiss's friend, former Senator Monning, in the last session. And we were very prominent in defeating that. So we do play a very active role legislatively. We do continue to monitor and produce position papers and statements on state and federal items, particularly with respect to white bagging legislation in this past year, as well as regulation of nonprofit budgeting for community benefit dollars. We support a lot of different types of things, and then we also are very active in things that we deem as particular threats to healthcare systems, such as some of the nurse staffing agencies and abuses that we saw there. Anyway, we remain constantly active on that front, and right now we are busy prepping with advocates and lobbyists in preparation for the new session, which are beginning both at the Nevada and California state levels as well as federal, and very, very active in all of these roles. And with that, I will turn it over to Mr. Ward.
All right, thank you, Ted. And we are going to end this presentation with some fantastic work on behalf of our 2 healthcare foundations. And so I want to point out some of the great work that Carly Epstein, our executive director of our foundations, and her team have done this year. And of course, none of it could be possible without the great community that supports us. So our Tahoe Forest Health System Foundation here in Truckee had a successful year, raising a little over $1.1 million this year. And we focused on raising funds for mission critical equipment, including the Velis robot that our orthopods use in the surgery suite. And we also completed a final year of a grant from the Health Resources and Services Administration. We often refer to them as HRSA. And that totaled over $600,000 over 3 years. And we received confirmation from the California Department of Healthcare Services of a $2.45 million grant to support behavioral health infrastructure costs here in the region. So these grants greatly enhance behavioral health services for our entire region, and we look forward to the work that the great team that's working on that will, of course, achieve. Moving to the Incline Village Community Hospital Foundation, they too had an amazing, successful year, raising a little over $3 million for Incline Village Community Hospital. And their primary fundraising has been focused on expanding surgical services, enhancing sterile processing, and providing behavioral health services in that community as well. So together, they worked on a team member giving campaign, which grew up to 260 participants from that of 181 in fiscal year 20. And the team members donated a total of $45,000 this year. And this year's funds donated were used to purchase the Lucas chest thumper for the emergency department here in Truckee. And together also they continued the Grateful Patient fundraising program. And this program allows patients to give a gift in honor of a caregiver in much more formal way. Here in Truckee, the Grateful Patient program, we had 265 gifts for a total of a little bit, 265,000 roughly. And in Incline Village, the program also had 41 gifts for about $47,000. Moving on to the next slide. So again, I want to thank the Administrative Council for their contributions to the development of this amazing and impressive annual accomplishments presentation. I want to thank Martina for her efforts as well. As a very new leader here at the health system, it's just amazing to see all of the work that happened in fiscal year 22. And it just makes me very proud of the team here. And I want to give Harry the last word.
Yeah, good evening, and thank you. This was a very special night for our health system, and I want to thank our team for sharing with you and for our community. Our community is always multitasking probably when they might watch our program, and so we really want to share with our community the amazing things this team is doing each year as we really strive to listen to our community and to improve what we do every year. So it's a privilege to serve our community for nearly 73 years, and we thank you.
Alice, you're muted.
Coffee. I was coughing. So, but thank everybody who has presented and all of our team for doing such an amazing job this year. I want to send out kudos to all of you. But while I send out mine, does the board have any comments that they might want to make on any part of the presentation?
Yeah, this is Director Barnett. I just want to say how impressed I am with everybody's diligence. Everybody goes beyond the standard of anybody's imagination and what we do. And I'm proud to be a director, and I want to thank everybody for the work they've done.
Thank you. Any other comments?
Yeah, I just would like to add, we hear bits and pieces of it throughout the year, but, when you hear it all bundled and put together in a presentation like this, it becomes like a real wow moment. So thank you to everybody.
Anybody else? Anybody from our audience want to make a comment on the presentation? Okay, seeing no hands, I want to thank everybody who is here this evening for spending your time letting us know all the accomplishments of our district, and look forward to a bigger and better year next year. Okay, so then we'll move on to, we pulled from the consent calendar the financial statement, and Director Barnett, you pulled it, and is Crystal Felix here?
Oh,
she's still here.
Yeah. So
I was just interested in staff comment on the fact that our first quarter revenues have been down below budget a little bit, and just what thoughts might be relevant to that.
So one of the most telltale signs is if you go to the statistics that were in the back of the financial package.
Yeah.
And what you'll see is for the first quarter, inpatient was over $6 million under budget. And that's almost entirely due to the fact that our ICU days were quite a bit lower than what we were anticipating. Let me scroll there real quick. So our admissions, we were planning on 422 admissions, and we saw 406. And of course, an admission turns into so many patient days. We thought what we budgeted in the matter of admissions would materialize 1,574 days. Well, we actually only ended up with 1,322. And when we looked at our ICU, we were expecting the first quarter to have 411 ICU days, and we only had 259. And with that level of reduction in the severity of the illness not being there, which is great for our patients, but not so great for our financials, really tipped the inpatient revenue down. And you'll see this trickle through to the ancillary services too, where labs for inpatients are down, imaging for inpatients are down. So it trickles throughout the organization when that one point is lower than what we had expected to see. We actually had the ICU closed for a number of days. I think, Jan, you might be able to expand on that. I think you said that we were closed for 8 days because we had literally no patients in the ICU. So just the volumes there were lower. COVID could be part of that. I think, Jan, you stated the number of patients that we see that have alcohol-related issues have been lesser as well. Great for the patient, not so great for our financials. It's a very odd position to be in. On the outpatient side, some of our outpatient statistics were down. MRI was probably the most notable. And that's because we didn't have an MRI for a little while because it had gone down. We had a problem with some cabling, and I can't remember the term for the other issue we had. Maybe Louis, you could, do you remember?
It quenched, right? So
that's what it was.
Which essentially means it just blew up from the inside in terms of, it essentially can happen under heat conditions or a manual press of a button. In this case, we actually had video evidence and there was no manual press of the button as no one was in the actual unit, and the heat wouldn't have done it as well. So this essentially was just really bad luck. So
yeah,
what it came down to.
So from late July all the way into early August, we did not have an MRI and had to postpone seeing those patients, or if they needed to be seen sooner, obviously we unfortunately had to have them go someplace else. So those are two of the biggest issues going on with our gross revenues. And then, as we all know, what we bill is not what we get paid. So when we talk about our net revenue, some of the biggest issues we saw there is a shifting in our payer. So we had planned for more commercial, a little less Medicare, a little less Medi-Cal, and those percentages shifted to where we saw more Medicare and less commercial insurance. And commercial insurance pays better than what Medicare or Medi-Cal pays us, so that lowered our net revenues. And in addition to that, with all the work on the rural health clinics, when the second floor of the cancer center got designated a rural health clinic, they made it retroactive to October of 21. And so we had to go back and reverse all those claims and put them back on the accounts receivable, which made our aging categories go up significantly because, you know, we're putting many months of accounts receivable back on our books. And so until we could get our rates set with the state of California and with Medicare, we had to hold those claims, and which requires us to reserve on them just in case for some reason we don't get paid on them in the future when we are able to bill them. So that unfortunately impacted our contractual allowances as well. So we've had a few unusual events so far this first quarter, and that's what's going on with our numbers.
Well, that's a very good explanation. Thank you. Any thoughts as to whether that trend continues, or any explanation for why less people needed those types of services?
Well, I am not a predictor of illness on the inpatient side, so I do not have a theory. Jan may, from a clinical perspective. The only other thing I could mention is that we know our patients are really trying hard to get in to see our providers, and that's been very difficult because the time frame has been extended so long. And so when our patients can't come in and generate that visit, it impacts several departments within the hospital. So if you come in and say you have a thyroid issue and you need to have your thyroid checked, so that's going to generate a lab. If you can't get into your provider, that lab doesn't get generated. So we're really working hard to try to improve access so we can get people into their providers, or patients into their providers, but that will definitely help some of those ancillary service revenues and those volumes coming up. Jan, do you have a comment on the inpatient side at all?
Yeah, on the inpatient side, unfortunately, our ICU is closed right now again. And we can't predict what happened last year versus this year. Like Crystal mentioned, I think a lot of it had to do with COVID. COVID hit us really hard in the fall last year. So we were extremely busy. And this year, we're just not seeing the numbers. A lot of it has to do with, you know, the behavioral health side is really working hard on our returning alcoholic patients who would spend days in our ICU. So we're not seeing those patients, which, like we said, is a good thing. And also, we're looking at other ways to, make sure we're not transferring patients that we could possibly keep here at Tahoe Forest versus transferring them down the hill. So we're really looking at stuff like that right now to kind of see, but we're not sure as to why this year is a bit more quiet than last year.
Well, thank you for all your efforts. That answers my questions.
Yeah, Bob, we're actually seeing utilization down across the board, across the country, in health systems, primarily because of inflation and whatnot. People don't have money, they seek less care, especially as more care is out of pocket right now.
That's a great point, Michael. I will say that I participate with the District Hospital Leadership Forum, which basically is a meeting we have every week with all the CFOs of all the district hospitals. And almost every single one of them has stated that their financial position this first quarter, they are in a loss position. I will say I'm very grateful that we are not in that situation. We are not as good as budget, but we are not in the loss situations that many, many other hospitals have experienced in that first quarter.
Yeah, thank goodness for that.
Any other comments from our board regarding our financial statement? Anybody from our audience? Okay, then I think we need to take a vote to approve the financial statement as presented.
I'll move to approve the financial statement as stated.
I'll second, Dale.
Okay, so it's been moved by Director Barnett and seconded by Director Shamblin, to accept the financial statement as presented. A vote, please.
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. And thank you, Crystal, for being able to answer on the spot all the issues that we had with that. Thank you again. I think the Finance Committee met this month. Is there any additional?
Yes. Yes, we did. Mary Brown and I met with Crystal and her crew. We reviewed in depth the EBS split dollar plan, much the same as the discussion we had tonight, but in a little more depth. We also reviewed the Chandler asset management account and accounts receivable. And we did go over the financials. Pretty much a lot of the stuff that we covered tonight, but we covered it in a little more depth.
Okay. Thank you. Any other committee reports? Then we'll move on to any board member reports. Anything from the foundation other than what's already been presented in the accomplishments?
No, they did not meet last month.
Okay.
Yeah.
All right.
Alice, while we're
Yes.
talking about the foundation, I just made note of the fact that we've been invited to the foundation mixer that's being held at the Rayleigh's One store. Was it November 17th?
Yeah. Okay. Now the board has been, and it's an event, so all board members can go and not violate the Brown Act.
Right.
As long as you don't talk about district business with the majority.
Okay.
I want to clarify that event is November 14th.
14th, yeah.
Oh, 14th.
Yeah.
Yeah.
We'll be at a board meeting on November 17th.
All right. Then that's a good point for my next comment is that for our audience to know that our November and December board meetings have changed their dates from our traditional. So it'll be November 17th and then December 15th that we'll be holding our general board meetings. So take note. And any other comments from our board closing? Remember that election day is November the 8th. If you want to change something, you got to get out there and vote for it. Okay.
Chair Wong, Crystal has a comment, I think.
Yeah, so I'm a pretty private person, but I think I should inform the board of directors that you are going to see a name change with me. I did just recently get married. You will see me going from Beth to Felix. So just didn't want to take you, blindside you a little bit. So lots of that's going to change. So
Congratulations.
Yes.
thanks.
Best wishes for sure from all of us. Okay, if there's no further business, then the meeting is adjourned. Thank you so much, board.
Thank you, Alice.
Thank you.
Thanks, everybody.
Yep.